Okay, sir. So the room is open.
So, Madhu, I think we can start now. It's 9:04 already.
Okay, we'll start now. So, good morning, everyone. I'm going to share my screen. Just 1 minute. Okay, is my screen visible?
Yes.
Yeah. So, good morning. As usual, we'll start with the small case first. This is a 60-year-old man with CKD on regular dialysis, came with history of extreme tiredness, difficulty in walking, difficulty in speaking, and jerking of the right face for the last 2 days. I'll show the video. Is the person's jerky movements like that. The bird very differently. Finding difficult to get the words now.
ഏത് വർഷം ഇന്ന് രാവിലെ കാപ്പിക്ക് എന്താ കഴിച്ചത്?
I'm asking what you took for breakfast.
എന്താ കഴിച്ചത്? എന്താ
He's trying to recollect with difficulty.
സംസാരിച്ചോളൂ, എനിക്ക് സംസാരം കേൾക്കാൻ വേണ്ടിയിട്ട് ചോദിക്കുന്നു. എന്താ കഴിച്ചത്? രാവിലെ എന്താ കഴിച്ചത്? പഴം. പഴം അല്ല പറഞ്ഞത്.
And you found tremendous difficulty in walking. In getting him on the floor.
ഇങ്ങനെ പോയി അകന്ന് നിൽക്കണേ. കീപ്പിട്ട്
No obvious clapping tremor. Okay, so what do you think the problem he has? On examination, he has found a weight finding difficulty, dysarthria, episodic jerking of the right face, and he walks with dragging of both feet more on the right side. The hymen functions normal, no focal deficit.
Sir, this looks like a dialysis encephalopathy with a focal fit, something like epilepsy or partialis continuum.
Okay, right. Any other opinion? Okay. In fact, MRI showed a small pontine infarct in the left paramedian pons. EEG showed diffuse generalized slowing. Put on oral lacosamide, which did not do anything any better for him. In fact, his serum creatinine was 15, serum potassium was 7.8, and he became completely already in daily dialysis. In fact, is it a myoclonus recurrently occurring or a focalization? To to me looked like a focal myoclonus. In fact, focal seizure is nothing but repeated myoclonus only. And he stopped lacosamide and everything subsided on dialysis. Just to show the case that renal failure can present with varied manifestations, I will just show another case of again CKD. Here, diaphragmatic myoclonus, limb myoclonus. Look at the abdomen. That's the thing. So, only to bring to notice that such involuntary movements can occur just by renal failure alone, not require any anticonvulsants. I think it's only to try a short case initially.
So I think, Madhu, do you think that the cause of this abnormal movement was the kidney failure or it was the pontine infarct? Because sometimes I have read in literature that sometimes even pontine infarcts can lead to abnormal movements.
But to my knowledge, but that abnormal movements usually tonic spasms which can occur.
Okay.
But it does not like a jerky movements like this.
Okay. Okay.
So, okay, shall I go to the next case? Proper case. Okay. This is a story of it's a long case. Story of a 16-year-old girl. Her complaint started, in fact, 2 years back as mild swelling on the right lateral aspect of the ankle. Few days later, patient noticed pain at the same area, which was increasing on walking. About 2 weeks later, patient noticed edema of the right lateral aspect of the ankle, which was also gradually increasing. About 1 month later, he took an injection, following which the edema subsided, but the pain persisted to a lesser degree for a long period of time. It remained like that. 6 months later, patient noticed worsening of the edema, which spontaneously subsided according to her 1 week later without any injection. Again, 6 months later, edema reappeared. Patient was seen by a rheumatologist, but he did not put her on any specific treatment because there was no sufficient investigation to warrant any treatment. 3 months back, patient noticed numbness along the right little toe and lateral border of the foot. Along with this, patient noticed difficulty in walking. About 1 week later, patient noticed some thickening of the skin. According to the Malayalam, she called it tadippa. Tadippa means some thickening of the skin on the right little finger, followed by numbness of the right little finger. Pain in the right leg got aggravated for the last 4 months and noticed difficulty in lifting the right foot and dragging the right leg. So this is the story of the patient. In fact, the patient was referred to me by the rheumatologist because already seen by neurologist earlier and investigated. I will show the investigation later on. And that's the story. So you want to hear the history of once again, total 2 year story. In short, pain and edema of the right ankle. Subsequently, the edema spread to the whole of the right leg. Then recently noticed numbness of the lateral border of the foot and lateral aspect of the little finger with some thickening of the skin and difficulty in walking, mainly in the form of dragging of the foot and heaviness. And that's the story of the patient. No complaints pertaining to the left upper limb or lower limb, no other, no fever, no arthralgia, no skin lesions, nothing else noticed. So this is the edema, if you notice, of the right foot. The whole right leg is edematous, mainly on the dorsum of the ankle and shiny skin. For examination, upper limbs are all normal, perfectly normal, and motor progression possibly. Section says normal. The finger pressures appeared weak, but I'm not sure it is bilaterally, symmetrically appeared. I could overcome, but since it is bilateral, I don't know whether it's significant or not. Finger pressures were right. It's normal bilaterally. First was FTA, and FTA was normal. But ADM was slightly weak on the right side, but not very convincing.
ഇങ്ങോട്ട് തള്ളിക്കേ
But that's more right is slightly weak.
വലിയ മടക്ക് നൂർത്തെ
Introshay were normal.
നൂർത്തെ
I mean, this part of the introshay is normal.
കൊണ്ടുപോവാ
Opponents' indices, opponents' policies and opponents' digitae minima were normal.
ഇനി ഇത് അറ്റം മടങ്ങാതെ ഇങ്ങനെ ഇരിക്കട്ടെ.
Mixed policies brevis was normal. Common sign was negative.
ഇനി വിട്ടെ ഇതിന്റെ ഇടയ്ക്ക് പിടി.
But introshay, this is normal on the left side. The fourth palmar introshay was weak. So that is really weak. She said she could not see. Look at the little finger; it remains abducted.
കൊണ്ടുവിടെ പിടിച്ചോ.
Remember the lower limb tone normal.
നേരെ പൊക്കം.
Oxybuses are all normal.
വിട്ടോ. കീഴോട്ട് തള്ളിക്ക്. കീപ്പോട്ട് തള്ള. വിട്ടോ. ഇതും തള്ള. വിട്ടേ. അതിനകത്തി പിടിച്ചോ.
Abductors, adductors are all normal.
ഇനി വടി പോലെ പിടിച്ചേ.
The extensor is normal.
പിടിച്ചോ. മതി വിട്ടോ. ഈ പാദം
Left angle, all muscles were normal on the left side. But the dorsiflexion was weak on the right side, whether it's due to the weakness or due to the joint problem, but he cannot passively also move the joint fully. But EHL was definitely weak. Finger extensors were weak. Flexor Thomas very weak, I'm not sure about it. But mild weakness is there, but not. Plantar flexors were normal. Right side again difficult because angle joint mobility is less. Inversion is also okay. Here also it's okay. Inversion very weakness. It's mild weakness. Inverters. The reflexor upper limbs are quite well elicitable on the viscous side. Finger pressure is also elicitable. Ejects are well elicitable. This by that actually. And eject is also this. Or get for normal end. And our aspects. In terms of sensation, she says she has numbness or that needle to fingers, only little finger.
ഒരേപോലെ ഇതും ഉണ്ട് വ്യത്യാസമുണ്ട്.
Then finger is decreased on the right side.
ഇതും വ്യത്യാസമുണ്ട്. വ്യത്യാസം മാറി നോർമൽ ആകുമ്പോൾ
She will tell when it is normal. That side is become normal.
ഇതും
That side is normal.
ഒരേപോലെ. ഇത് രണ്ടും ഒരേപോലെ. ഇനി കാലില് ഈ കുത്തുന്നതും ഇതും ഒരേപോലെയാണോ?
There is no difference between right and left. The only area of decrease is the little toe on the left side or the right side.
ഈ കുത്തുന്നതോ അവിടെ വ്യത്യാസമുണ്ട്.
That is decreased.
ഇത് വ്യത്യാസമുണ്ട് അല്ലേ? അത് മാറി നോർമൽ ആകുമ്പോൾ പറയണം. നോർമൽ ആകുമ്പോൾ പറയണം. നമ്മൾ ഈ ബയോപ്സി ചെയ്തതിന് മുമ്പേ ഈ ഞാൻ വരച്ചിരിക്കുകയാണ്.
She had undergone a nerve biopsy, but she says the numbness was present even before the biopsy was done.
തീർച്ചയല്ലേ? ഓക്കെ. ഇനി ഈ കുത്തുന്നതും ഇതും തമ്മിലോ?
Sensation of the sole is normal. Only along the lateral part of the
വൈബ്രേഷൻ. അതേപോലെ ഇവിടെ ഉണ്ടോ?
vibration is appreciated normally in both upper limb.
ഇതോ
Normally present.
ശ്രദ്ധിച്ചേ പോണ്ടല്ലോ.
Vibration is also normal.
ഇതും പൊങ്ങട്ടെ.
SLR was negative. Joint sensor is normal. There is no nerve thickening. She could stand on heel. Probably because of joint problems, she is not able to do the full restoration plantar flexion. This is the way she walks, as if weighted right over. The patient, the epidiasis walk the
ഇങ്ങനെ എടുത്ത് നടക്കാൻ തുടങ്ങി എത്ര നാളായി? 2-3 മാസം. എങ്ങനെ മോനെ? ശരി.
So on examination, edema the whole right leg below knee, mainly over the right angle. Motor system, left upper limb, tone normal, power normal. Right upper limb, only definite weakness was the fourth palmar intrusions. Curry weakness of the right abductor digiti minimum. Most of the intrusi, adductor pollicis all normal. The lower limb, tone normal, power right lower limb, weakness of the right EXL and extensor digitorum were definitely present. Other things we are not very sure. Flexor pollicis, longus, and evertus were not very convincing. Rest of the muscles were normal. Left lower limb all normal. DTR all brisk. Angle jacks were not brisk, normally acceptable. Pandas flexor, sensory. Right upper limb, sensory dulling of pain or the middle two fingers up to the middle of the palm. However, the vibration JPS sensation is normal in the fingers. Left upper limb normal, right lower limb sensory dulling over the lateral part of the foot, and the numbness was present even before the biopsy. SLR was negative, no nerve thickening, no hypopigmented patches. So, what do you think the possibility in this patient and what is likely etiology you can keep in mind? It's not a simple case.
Mononeuritis multiplexer.
Okay, mononeuritis, but what is the peculiarity of this mononeuritis multiplex?
It's mainly edema is there, some autonomic.
The autonomic is very prominent, and the edema is extending beyond the territory of the nerve distribution.
That means a element finding, an element syndrome involving motor and sensory in the non-contiguous areas without any UMN findings. And
so what could be possible etiology you would like to keep in mind?
I would think of some infective pathology, probably leprosy, or maybe some rare infective condition which must be causing recurrence of the same issue.
In fact, Hansen disease is one of the strong possibility one should consider, because the sensory loss is mainly cutaneous nerves are affected. See, one of the point favoring Hansen is that she's got sensory loss in the skin, but the joint sense and vibration sense, the same area preserved. That means the deep nerves which carry the proprioceptive input are preserved. Cutaneous sensations are low. That is that's in fact favoring a Hansen disease. That means the disease affecting cutaneous nerves.
But Madhu, was there thickened nerves? Was there thickened nerves?
No thickened nerve and no tenderness of the nerves. No patches were seen.
Lyme disease is also getting recurrent new neuritis.
Yeah, I Lyme only. I never seen one. It is because neuritis can occur. They got a characteristic cutaneous lesions, other systemic involvement with them, like arthralgia, static involvement, etc. This I don't know. If you ask me if it's possible or not, it may be possible, but I have not seen one case before. It is very rare in India.
Amyloidosis.
Amyloidosis predominant involvement is autonomic nervous are affected, no? And that too central autonomic cell fibers, deep autonomic fibers are affected, post-lipotension, impotence, things like that. Here the cutaneous nerves are affected predominantly. And the disease is confined only to one nerve, mainly so one limb. And again, not fitting with the pattern of a nerve. There are many points against, I agree with you. It's not a straightforward diagnosis. Okay, you can give amyloidosis also because of the profound autonomic involvement in this patient. Okay, what investigation you want? In fact, there are some investigations done before the present admission. I will show that before what we did. They are extensively investigated in many places. 2 hospitals you have seen. This is a nerve conduction done in the first hospital. This is done on 27 May. The right median and left median normal, as expected. This is the right ulnar motor conduction pickup from abducted digit minimi, normal amplitude. This is the left ulnar pickup from abducted digit minimi, a suspected normal amplitude. This right ulnar pickup from the FTI. The doctor neurologist correctly did pick up the FTI because he found out the weakness of the fourth Mohan crochet, but that potential was normal. That means there is that muscle or nerve is only some fibers of the nerves are affected. It is not a deep branch of ulnar nerve per se. If deep branch of ulnar nerve per se would have been affected as causing the fourth palmar interosseous weakness, it should have affected the FTA. The FTA is not affected. Only fourth palmar interosseous. That means some pathology which is affecting that particular digital nerve is affected. That's the thing you have to keep in mind. Because this pattern which is not fitting with the deep branch in them. You can argue that the first muscle affected in ulnar nerve palsy is the fourth palmar interosseous. That is the so-called Wartenberg sign. But even then, in that case, the conduction should have shown some abnormality in the FDA, which was not there here. That is the FDA. Then let's see the sensory potential, right? Normal. And only abnormality picked up from the left dorsal ulnar cutaneous nerve, slightly less on the left side. But that does not go with our present patient's finding. Now, coming to that means that probably the large fibers are preserved. Probably the small fibers are affected in this patient. Middle antebrachial cutaneous nerve, median nerve, sensory potential is normal. Lower limbs, right peroneal normal, right tibial normal. Sorry, right peroneal from the EDV pickup was absent on the right side because probably because of the edema itself or because of the muscle. There is also evidence of muscle weakness in this patient. Each was weak. Come to the sensory again, supraperoneal could not be obtained, obviously because severe edema was present. And right, oral could not be elicited. This may be due to the nerve biopsy, which is not. But according to her, the numbness was present earlier also. Whether that part we can't commit now because nerve biopsy is not been done. But in the area where the sensory loss was there in the right ulnar nerve, sensory potential was not. FM latency was it is on the which nerve limbs normal, lower limb, peroneal did not obtain it because obviously the amplitude is very low. Now, repeat conduction was done in another hospital about 1 month later. Showed essentially the same thing. The right median nerve, everything normal. Only finding was decreased amplitude in the right peroneal nerve, probably because the edema itself. And FA latency were normal. And the sensory potential were normal in that this thing, except the right sural. Where the sural was elicitable because this was done before the biopsy. This is done before the biopsy. So other investigations done elsewhere. Blood chemistry was normal, HIV screening normal, HPS AG screening negative, HCV negative. Then LFT, RFT, serum proteins, CRP, thyroid functions normal. The rheumatologist did ANA and ANCA, which are also negative. Quantiferon TB gold was done. They did an MRI of the right foot and ankle from the hospital. It showed a tiny subchondral cyst in the anterior aspect of the talar bone. It's not down bone, with corresponding area in the tibia, also showing tiny subchondral cyst with marrow edema, early anterior impingement, diffuse subcutaneous edema surrounding the ankle joint and dorsal aspect of the foot, minimal ankle joint diffusion. So this is the report. How much significant it is, we don't know. Then they did arterial and venous Doppler was done. No evidence of any significant stenosis of the right lower limb arteries. No evidence of any DVT. Cellulitis around the ankle and foot. No located crutch. So what else you need now?
The ultrasound of the peripheral nerve in the right lower limb.
Ultrasound that you think with such severe edema you are not able to pick out. Anyway, you can ask for a nerve biopsy, no? That's a better thing.
Yeah, to exclude hand cells, any thickening is there.
Nerve and skin biopsy. Nerve and skin biopsy.
Yeah, perfect. That's the thing. So skin biopsy was done. This is a skin biopsy. No evidence of Hansen disease. Similar pictures can be seen in early morphia. Confirmation may need more samples to be evaluated. Skin biopsy was from the dorsum aspect of the right ankle, near that some patch they said notice, maybe not. That is what I written. Hyperpigmented anesthetic patch, right foot dorsal foot. But there's no evidence of Hansen disease. The nerve biopsy was done. This is from Srijitra. And you see the impression. Mild to moderate uniform chronic axonopathy. Small fiber more than large fiber. That's what we expected according to the conductor study for the right sural nerve. Etiology of small fiber neuropathy is not evident in this biopsy. Okay. Now what do you want?
So this Jogren syndrome, that is.
You want ANA profile, no?
Yes, sir.
Okay. So in the present admission, when he was admitted, I did a repeat blood chemistry was normal, CAF normal. ANA profile was also normal. With SSP mild is not significant. I showed to the physician.
That Congo red is awaited. Congo red.
You still think this could be a amyloidosis, no?
Sir, what about sarcoidosis?
No. Does it fit with sarcoid like this edema and or confined to one limb remaining for 1 year? I don't know. So see, sarcoid and tuberculosis can present anyway. So that's a thing you can keep in mind, but no evidence so far. Okay.
So what about X-ray chest and Mando test?
It was normal. Then Mando, I don't know that. The coniferous cold was exercise test was normal. Ultrasound abdomen was also. They all been extensively done from the other hospital. Because they consider tuberculosis one possibility. So that part they looked on that. That's why coniferous cold, etc. was done.
Anatomical diagnosis is mononeuritis multiplexus, sir, or something else?
Yeah, it is mononeuritis multiplex neurologically, but some peculiarities there in the mononeuritis multiplex. It is affecting the cutaneous nerves. Cutaneous small fibers are affected. The large fibers are preserved.
So even in the nerves, there are difference because all the parts of the nerves are not affected, isn't it, sir?
Exactly, that's what I'm trying to say. So that means that this disease is, all part cutaneous nerves are affected dominantly. See, the deep nerves, for a nerve contains deep fibers and cutaneous supplying the skin. The deep fibers are responsible for your joint sense, vibration sense, and the reflexes. They are preserved. But the nerve, the branch of that nerve supplying the cutaneous nerves, then something superficial is getting involved.
Sensory perineuritis or something?
Yeah, that's one condition which is called sensory perineuritis, which affects just like Hansen disease, as Joy was telling. That can migrate. Migraine to sensory perineuritis can, but they don't produce such autonomic involvement in this way, like this.
Sir, if the small fibers are involved, invariably autonomic will be gone.
Yeah, this autonomic means in amyloidosis, it is not the cutaneous. The autonomic means the cutaneous nerves, autonomic fibers are affected. Small fibers are carrying autonomic fibers also, but they are the cutaneous nerves are affected. That is when Hansen you get loss of hair and edema in the circumscribed area. But Hansen will not produce postal hypotension, impotence, etc. due to that, due to the autonomic neuropathy. You got the point, because the Hansens affect the cooler parts of the body. But recently there are case reports, or even Kadalkar has shown that Cancer can affect dorsal root ganglion, spinal cord, all can be affected. But that picture will be different. Clinically, that will be different.
A paraneoplastic thing.
But is it a known syndrome like this? Anyway, you know what we did, I'll show you. So we, in this hospital, I told you, we have got a good radiologist. He pursues the case. If he's got a doubt, he asks everyone. He asks the dermatologist. He himself calls the dermatologist. He himself calls all rheumatologists, his own radiology colleague that he does. So we took an MRI of the leg.
So non-lepromatous mycobacteria.
Yeah, that's a possibility, but skin biopsy did not show anything. In the nerve biopsy did not show anything. So what shows edema is not only in the angle, it is spreading into the muscle as well as the subcutaneous tissue. I'll show the next picture. See, this is the edema of the muscle affected area. This is the normal muscle. The muscle is edematous, subcutaneous is edematous. The bone does not appear to be much in the tibia. So MRI of the leg showed diffuse edema in subcutaneous tissue and muscles. And in the MRI angle, it showed only mild effusion, which according to me is not very significant, can be sometimes seen. The joint per se is normal. Then what he did, he took an MRI of the hand, also that is his interest. He found the still image shows hyperdensity in the same area where the thickening was there. So she was pointing out some thickening of the skin and subsequently numbness spread along with it. And that area he found some hyperintensity. This is exactly where the patient pointed out the thickening was there. This again can make it very clear now on the window with suggestion. This again picked up in the axial cut. So small area hypertension in the lateral part of the right finger and still remains. Then he took a CT scan. This is all he did himself because he wanted to know what the condition is. So CT cut was taken. He found out erosion of the talus bone and the metacarpal bone. I'll show the little more compared to that. You can compare with the right and the left side. Here you can make it very clearly on the right compared to the left side. The talus bone was also having erosion. This is the video. Also the compare right and left is being compared. I'll pause for some time, then you can find out that the affected area has got a bone resorption. The bone resorption on the right side. Bone right and left side you can compare. That's also you can compare. So that means there's some trophic changes which are affecting the skin, nerves, as well as bone. So physician was consulted. He said, "You don't know what is he dealing with? I can't give an opinion." So I consulted an orthopedician. He also said, "No, I don't know what." Since the radiologist has this possibility, then it struck to my mind that is the diagnosis. You know what could be the possible diagnosis?
Sympathetic osteodystrophy.
Exactly. Sympathetic osteodystrophy or Studex also. It fits in classically with sympathetic osteodystrophy. In fact, that's a long period of time without any progression, 2 years duration. It's called Studex dystrophy or sympathetic reflex sympathetic dystrophy. RSD, our pediatrics all comes under this category. I'll show you another case. This is very, very common, but I have not.
Madhu, 1 minute. Can I make a point?
Yeah, please.
This reflex sympathetic dystrophy, can it involve 2 separate limbs at the same time?
Yes, I'll come to that. I'll show the little literature. I will show it.
And two questions. You can please answer that because usually we are used to having in 1 limb. Here it's in 2 limbs. Second is that usually many times it is in response to some underlying insult like a stroke or something. Here, what was the insult? That's all.
Yeah. There was no incident in this patient. Usually it was preceded by a trauma which is very trivial. Yeah. And the trauma need not necessarily correlate with the development of the edema, maybe time gap. And even if the trauma is there, the effects may be at a site very distant from the site of trauma.
Okay.
So the trauma is inciting factor, but how does it cause this dystrophy? We don't. Still is an enigma. I'll show some of the slides. I take a look at the slides.
So in this case, is there any neuropathy addition?
There is neuropathy. There is sensory loss is there. No?
A motor also. There is a foot drop also.
There's not foot drop is not very definite because of the joint ankylosing, but EHL was weak and the finger regions were weak. And no doubt about the both palmar individuals very, very weak. You cannot adduct the little finger at all. That means the branch, that's the area where it's affected. That subjacent, whatever structures are present subjacently, they get involved.
So what's the incidence of the pseudotic dystrophy in Hansen's?
Hansen can put his autonomic involvement and that all confined to the skin and can also affect the bone if the late stages. Bone resorption can occur. But this is the edema, etc. That's confined to the area of affection. But here extensive involvement. And sometimes you can present without any nerve involvement at all. This is what is dystrophy. I'll come to that. I'll show you 2-3 cases. This
Sir, whether any sympathectomy would help this patient?
Wait. I'll come to the treatment part. Let's come to the diagnosis because sympathetic is one option for reflex sympathetic dystrophy. You are perfectly right. Now, this lady has another patient some time back, I've seen 2 months back. Pain and swelling on the right hand of 2 months duration. Mild difficulty in carrying out movements in the right hand. This is the hand. This is the mild form of RSD. She has got edema and pain, unable to flex the fingers totally. Look at the edema of the right hand. And she improved totally 2 weeks time with steroid. Again, 3 months later, performance she came with the same edema and the same way, with pain and difficulty in moving the limbs. Why it causes recurrently? She has no inciting factor. It's very common. Just 2-3 slides also about this condition.
That could be unilateral rheumatoid arthritis, sir. Unilateral rheumatoid arthritis described in hands.
Yeah, it is not the joint which is affected. It is the edema and swelling first which comes first. Joint one can occur, but not like that. Not, I don't know, better confined to everything be affected on one side will be unusually for rheumatoid arthritis. Nerve involvement, cutaneous nerve surroundings are affected. Now, this CRPS, or is known as reflex sympathetic dystrophy, describes an array of painful conditions that are characterized by continuing and spontaneous and or evoked regional pain that is seemingly disproportionate in time or degree to the usual course of any known trauma or other lesion. Usually starting in a limb, it manifests as extreme pain, swelling, limited range of motion, and changes in the skin and bones. It may initially affect one limb, then spread throughout the body. 35% affected people report symptoms throughout their whole bodies. These are some pictures from the net which has collected that the right leg may be as severe as this thing that can develop dystonic positioning can occur. Can sometimes occur bilateral upper limb. Sometimes may severe edema as our patient had, like this is in the upper limb, another patient. So is a neuropathic pain disorder defined by the presence of distinct clinical features including allodynia, hyperalgesia, pseudomotor and vasomotor changes, trophic changes, even motor disability. So 2 subtypes CRPS, one is reflex sympathetic dystrophy, other is causalgia secondary to nerve trauma. I think I'll just run through that. They can present with allodynia, hyperalgesia, vasomotor dysfunction, alteration, sweating, skin color, temperature, trophic changes, hair and nails. There may be also weakness and decreased range of motion and dystonia may be there. So this can begin immediately, days or weeks after injury, usually in a distance immediately. Rarely the onset can be months after the injury. Usually one limb is involved, but rarely involvement can be bilateral, and very rarely 3 or 4 limbs can be affected. Can be acute or chronic. I think I'll skip this slide showing the features. Okay. So this is the case in this patient.
So Madhu,
Yeah.
Thanks. I think it's a great case and great learning. We used to have something called shoulder hand syndrome following strokes on the
Correct.
hemiplegic side, in
Exactly.
which there would be shoulder pain and also swelling of the hand. Is
Correct.
it same or is that different?
It's exactly the same. These are all come under CRPS.
And one of the treatment options these days being given is platelet-rich plasma.
Yeah, but I'll tell you, man, almost all the cases shoulder hand syndrome following myocardial infarction or diabetes mellitus, I give steroid and active physiotherapy. And every 2 hours, I ask them to do physiotherapy and steroid. I think I have not seen a single patient who has not responded.
Oral steroids or local steroids?
Oral steroid.
Even if they are diabetic?
Yeah, diabetic. I give diabetic steroid. I give diabetes patient, I give depressor. Other patients, I give some other major penicillin. They respond very well. The first dose of steroid, second day, the pain will subside.
Okay.
But you have to do the physiotherapy, the shoulder hand syndrome will subside. Any questions in this case?
No, I think
So
that, yeah, please go ahead, sir.
sir, in the initial she complained of pain. That is the etiology for the CRPS, or that is the starting point?
No, the pain, edema, everything is part of the disease process. And what is the disease is basically a sympathetic dysfunction or an autonomic dysfunction affecting the sympathetic nerves. What caused the dysfunction? We do not know. It is usually incited by a trauma or other stressful condition like myocardial infarction. I did not show this. There are many conditions which has been can produce pain. So that's inciting factor. But how does it result in the sympathetic disorganization? We still did not know. I'll just show the causes. I will skip it.
I think if this patient had come just with a swollen, painful hand,
Yeah.
we would have probably thought in the beginning only it can be reflex sympathetic dystrophy. But
Correct.
her presentation was little different. It came like in 2 different limbs, and also we didn't think of it. We thought of mononeuritis multiplex.
Correct. That's the because I say got the because in fact I was not able to make the rhinos initially. I was thinking with for many people, nobody could, and the radiologist was showed he only did the CT scan and picked out the Roche and all, showed the affection of the various structures. Then he said this is most possible diagnosis. And these are the various, I think you can see the slides, somebody asked the causes. It can occur in usually with trauma, fractures, contusions, sprains, crush injuries, surgery. Even IV cannulation can produce sometimes without trauma, following from prolonged immobilization, increased psychological stress during physical injury. These are all things which are reported to produce.
I think stroke comes under that immobilization thing. Because of immobilization.
Correct, immobilization.
Yeah, Madhu, I just wanted to ask you one related question. See, I have one young man at this time under my care at this time who has a severe. He has got an ulnar nerve involvement, ulnar numbness, and also swelling. Something similar. And this is for the last 1 month, swelling in his hand and ulnar nerve sensory distribution. So on examination, they're same ulnar nerve and mild swelling. And in the nerve conduction, ulnar nerve amplitude is little bit reduced. But on ultrasound and MRI, both of which are showing thrombus in the ulnar artery. Thrombus in the ulnar artery, but there is no compression on the ulnar artery from outside, just thrombus in the ulnar artery. So what, I don't know, have you seen this thrombosis of the ulnar artery alone? What is this condition?
No,
and one more thing, we turned out to have polycythemia, about the hemoglobin was 19 or so. So have you seen this kind of a thing?
No, I have never seen artery thrombosis.
Okay.
Last week, I discussed one case of a tibial artery involvement producing nerve ischemia, producing neuropathy. Last week. So
this can happen. This can sometimes happen. Yeah. Okay, sir.
So probably something later to that.
Yes, sir.
So patients complain of pain, reflex sympathetic dystrophy. Do they have mononeuritis multiplex also with weakness?
No, in that case, they can develop neuropathy because of the subjacent nerves get involved. The muscle can get involved. Bone can get involved.
Can we be 100% sure this is not Hansen's disease, although the biopsy is negative?
No, that part one cannot be 100% certain, but skin biopsy is negative, and I put her on steroid. Second day she started having the pain decrease, the edema became less. Second day. But the swelling is not decreased much, but little bit, but pain subsided. So what I'm trying to say is that nobody can say it is not hands. That's the first possibility one should keep in mind. But no evidence. Skin lesion is not so, nerve biopsy not showing mycobacteria. And the picture is also not favoring because the edema is spreading throughout the whole limb up to the ankle, up to the knee. That is that or without any effect in the nerve there, producing edema.
So could it be another any autoimmune phenomenon because such a rapid response in day one with steroids in CRPS? Can it happen? Sir?
No, I did not get you. Can it really?
Sir, in CRPS, usually it takes time to improve, sir, but improved with steroid in day 2. So could it be any vasculitis or another autoimmune which is not detected yet?
What other autoimmune? Is the just because she improved steroid does not make autoimmune, but does not fit in with any autoimmune. And we have so all the workup for autoimmune which was done was normal. The vasculating profile, everything was normal. CRP was consistently normal. Cancer was normal. Everything was normal.
Madhu, are you going to treat her with Hansen disease treatment also?
No, only steroid. Put her only on steroid. But the dermatologist said it's not Hansen. No features of fitting with Hansen disease.
Okay, sir.
But
Next.
why, sir, that localized skin, this thing, the skin biopsy that we have taken, why it is so localized?
That's a thing which is described in CRP because that's the structures are even can affect the skin also it can be affected because the trophic changes. So what is that localized area? We don't know. But that's the thing which can occur in sympathetic involvement. You get thickened skin, shiny skin, the nail skin dystrophy. They all occur following an autonomic nervous system involvement. That is probably affecting the vessel and they can produce altered permeability of the capillaries. In student district, one of the postulate is that the capillaries get involved and that produces altered permeability and slow resorption. That is one explanation for the resorption of the bone also.
So we can take it as a diagnosis of exclusion or dialysis.
Yeah. But that fits in with it. So why we have come to the diagnosis here, see it as investigated fully for all investigations. Nobody could pinpoint any diagnosis. Which non-syndrome like CT disease, cancer disease, are all excluded. That is why, because I would have first considered Hansen as possibility if I send me first, but no clue.
Sir, is it necessary to show bone involvement to make this diagnosis? Suppose if there was no bone involvement.
No, need not necessarily be there. No, need not be there at all. There are additional clue to say that it is involving extensively. That this patient, unlike a usual reflex symptom, it is a severe one. This has been for 2 years.
Sir, one doubt.
Yeah.
Suppose if the radiologists have not pursued this thing, treat it as a leprosy or?
No, I wouldn't treat leprosy. I will send to a better person for another diagnosis. I'll go on seeking help. That's all. Go on referring to me, other people getting opinion. That's a bit. Because how can you treat with Hansen disease treatment without any proof?
Yes,
That's not correct. Yeah. Okay, so I'll go to another case. Not very interesting case like this one. It's a story of a 67-year-old diabetic female. She came with this story. That story was written by her daughter. And on May 26, 2021, she woke up from bed and could not stand properly. She slumped to the bed, again tried to stand, again fell to the floor. She needed support of the family members to walk. Second day, the condition remained static. Third day, she needed support of children to take a step forward. She was advised down to the doctor, advised injection renal for 10 days. This is the person they give the history day by day. She took bed rest since she found difficulty in walking. Injection was started on the 6th day. 9th day onwards, some change occurred and was able to stand with support. By 10th day, she was able to walk without support. This is a story given by the patient and the patient. Why she has come now, even though the weakness is improved, she feels some bulging of the left portion of the buttocks region. Some swelling near and during defecation, she feels something is filling her left buttock, some heaviness in the buttock. She feels imbalance while walking, while standing and walking, because she said the hips are not steady. That is why she came to me for these complaints. Even though she is able to walk without support, which was not able to. She feels cotton wool sensation over both feet. These are all present from the very beginning, but this has not subsided. That is what she has come to me. Then there's one past history. She helped cutting a tree in her compound 1 week back. This is story. Now I go to the examination. The Taylor's examination is normal. Since her complaint was difficult to get up from sitting position, I thought I will examine completely whether upper limb tone power normal.
എൻ്റെ എല്ല് പൊട്ടണം, അതുപോലെ പിന്നെ പിടിച്ചോ, വിട്ടേ, എങ്ങനെ പിടിച്ചു, നൂർത്തി വെച്ചു, എൻ്റെ വെള്ളി തൊട്ട് മൂക്കി തൊട്ട് അങ്ങനെ ചെയ്ത് കൊടുത്തു മൂക്കി മറ്റേ
He's a diabetic about it. The tone was normal in the lower limb.
ഈ കാല് പൊക്കണം, പൊക്കി പിടിച്ചോ, വെളുത്തി പിടിക്കമ്മ,
Normal proximal.
വിട്ടോ, ഇത് പൊക്കി,
Reflex was normal. Knee extension was normal. Dorsiflexion was normal. Then I noticed that she has got a claw foot on the left side. Did you notice that? Not on the right side. DHL was weak bilaterally. Plantar flexus are normal. Pivotus is normal. This position hip abduction normal. Hip extension normal. The reflexes in the upper limbs normally elicited. The reflexes are diminished all throughout the diminished. Triceps is elicited. Triceps is normally elicited. But knee and ankle jacks, knee jacks are very sensible, ankle jacks are absent. Ankle jacks are absent.
വിട്ടേ, അല്ലല്ലേ, കാലല്ല, കൈ വിട്ടമ്മ, കൈ വിട്ടോ, ഒന്നുകൂടെ മുറുക്കിക്കേ, മതി, വിട്ടോ.
Left ankle was also absent.
വിട്ടമ്മ, കൈ മുറുക്കി പിടി, ശരി, വിട്ടോ.
Plantar was spectral.
ബലം കൊടുക്കാം.
And look at the leg left side. Correct claw foot.
ഇതും തമ്മിലോ വ്യത്യാസം ഉണ്ടാവും.
sensory issue is with inconsistent.
നല്ല വ്യത്യാസം നീ പറഞ്ഞാൽ മതി. ഈ കുത്തുന്നത്
There's not much of a difference between distally and proximity.
ഇല്ല, ഈ കുത്തുന്നതും
Here it's telling little less, but over the little toe.
ഒരു വ്യത്യാസം.
Here she's telling little less on the lateral part of the leg. Look at that. That is normal. That is weak on the left side. The adductor hallucis is weak on the left side.
പിടിച്ചോ 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 പിടിച്ചോ. ഊരാൻ സമ്മതിക്കരുത്, ഊരാൻ സമ്മതിക്കരുത്. നമുക്ക് കാല് പൊക്കാൻ നമ്മൾ നോക്കി ഊരാൻ സമ്മതിക്കരുത്. കണ്ട ഇത് പിടിക്കുന്നില്ലേ, ഇതേ പിടിക്കുന്ന പോലെ ഇത് പിടിക്കണം. പിടിച്ചോ പിടിച്ചോ, താഴോട്ടാക്കി പിടി. ഉണ്ടെങ്കിൽ ഉണ്ട്.
Vibration normal proximity.
ഇപ്പോഴേ ഉണ്ട്.
Look at the angle, but absent the toes.
ഇപ്പോഴേ അറിയാവോ ഇല്ലയോ? ഇപ്പോഴേ
The vibration is decreased over the toe on the left side compared to right. That is in bed. Not able to see. In bed. SLR was negative. I was asking you where she said the heaviness of the back, certification. She was pointing somewhere there. She's somewhere telling somewhere on the back of the lower trunk and buttocks. He can stand on heel. He can walk on toes. He can standing on one foot. Neck. Okay. This findings confined lower limb, tone normal, profound deformity on the left side, power weakness of both EHL and left adductor hallucis. Both angle checks absent, rest were normal. Sensory impairment over the left little toe. Impaired JPS sensation over both big toe. SLR negative. So what do you think the possible diagnosis, cytoplegia and diagnosis?
How long is the history of the left claw foot, sir?
No history. With this one examination only we found out. How long it is there, we don't know. They never noticed that. The problem started about 2 months back, May, June, July, 2 months back.
Bilateral S1.
Bilateral?
L5
L5 radiculopathy. Okay.
Tibial part of the sciatic nerve is
Tibial part of the sciatic nerve located on bilaterally due to possible etiology. And she's a diabetic, and blood sugar at the time of admission was 400.
so bilateral ankle reflexes could be due to the bilateral peripheral neuropathy is the diabetic, but the claw foot deformity and the adductor has a specific weakness could be explained only by the tibial part of the sciatic nerve specifically involved.
Yeah, it
Can be higher up in the lesion.
Can be due to a tarsal canal syndrome.
The EHL also is weak, no? External cells.
External cells also is weak.
Yes, so that cannot explain.
Yeah, that cannot explain that thing.
She has something in the back, some symptoms. That is why
Exactly.
upper part.
She has some heaviness in the back.
In the high up buttocks, sir, the tibial part of the sciatic nerve is coming can be pressed.
Remember, she was pointing to the lower back and the buttocks.
Yes.
That cannot explain the tibial nerve involvement.
Tibial part of the sciatic nerve.
Yeah. Tibial, that is very unusual. No, the sciatic nerve is almost always it's a convolutional division get affected. That's the most vulnerable part.
A mononeuritis multiplex.
Yeah, that's another possibility. But the symptom was notice the symptom. She cannot get up from one day morning. She got up, she slumped to the coat. That's why she presented. So I was wondering whether it's a mononeuritis or is it something like a episodic paralysis or a GB history wise. But the symptom of pain and all these things took away from episodic paralysis. Some problem was heavy nerve is pointing to. That is a complaint. And she said, well, defecating, something is sitting in her, what do you call rectum. That's the kind of feeling she's getting. Okay.
That's something cornerstone also should be to be considered. Corners also to be considered.
Yeah, right. So she in fact went to consult another neurologist, thought could
Yeah.
diabetes from neuropathy or something like that. She put her on treatment with injection nerve, and that is why he improved. She improved injection. See the history you got. Second day of starting injection nerve, she started improving. Okay, that's the story. Let us see the nerve conduction. The right peroneal shows decreased amplitude. Left peroneal, where the claw foot was there, the amplitude was normal. Tibial was also the amplitude is normal on the left side. And corroborating with that, the sensory potential also decreased on the right side. Left side is normal. And I don't think it's a technical fault because my technician is very good, but I have personally see that they do it correctly. If it does not tally with that clinical situation, they come and ask me, sir, this is not been, is it correct? No, then I will say, you go and recheck again because it has to tally with the clinical job. She asked you to recheck. She said, it is not obtained on the left. So I checked, I have checked left again and again. That's what is suspected, seeing the clock. She said left side is normal. So what do you want now? This is the mild increase in the, normal. You can take it as a phase latency is normal. 58, 59, likely.
MRI of lumbar spine.
MRI of the lumbar spine, because anything else, how do you explain the decreased amplitude in the same map on the right component?
Could be diabetic related. We don't.
Yeah. You think it's unrelated? Or related? Okay, it's still unrelated because it cannot explain the patient's any of the symptomatology, any of the clinical findings also. So you can, yeah.
No edema. Edema.
Edema. You saw that there is no edema there. Now, what are the electrophysical tests you would like to do now? Now, the clue is that she complained of we got weakness and wasting of the weakness of the adductor hallucis. But if it was due to Turner syndrome or due to tibial nerve, the adductor hallucis should have been decreased amplitude on the left side. Okay, so that is one point. Second thing, she complained of decreased sensation over the lateral, over the little finger, little toe. Again, in the sural nerve or the S1 distribution. So, what else will you do? And the small muscles of the foot is supplied mainly by the S2 and not S1. S2, you can't do any nerve contraction study.
H reflex.
Very good. I'll do the H reflex. The possibility is that it's a diabetic neuropathy with a diabetic amyotrophy. That's why she's not able to get up from the bed on one day morning, an unrelated neuropathy. Or is it something, it's a record icon. So what if you need? H reflex was absent by that. See, the tibial potential is normal on the left. and H was absent. That means lesion has to be proximal problem in the caudal vein. Okay. So then we do an MRI study. But then the question may arise, is H surplus due to a technical fault or not? But H surplus is very easily elicitable, not a problem in obtaining H surplus. But still it can be, since bilaterally present or bilaterally absent, got to be little careful. So what else would you like to do? So I went and checked the patient once again. Okay. Protection again, because dependent, if S1 root is affected, S1 is affected to be weak. This is the right side. It's on the normal side, that's the left side. Please mute, please. He is weak on the left side. And she was complaining pain there when you were doing that. So whoever is listening, please mute your mic, please. Only unmute when you want to ask questions, please. So she had weakness of the left hip abduction, which was not detected when you was examined during while lying down position. Because only in this position you can check power against the gravity. Very often to save time, we do what we do. The lying down position also, we just check the abduction. We will not do it in the left lateral position. So always you check muscles of the proximus or lower limb. They are very strong muscles. So you have to put the muscle in the offending position, the most disadvantaged position for the muscle. That means the muscle should act against gravity. So this is the position in which the muscle against gravity, because in this position, the whole lower limb weight shares sustained with the hip abduction. So you can easily check the difference in the power meters. So in fact, left hip abduction was weak. Now we have got two clues there. She has got left S1 radiculopathy, probably S2 radiculopathy as well. L5 probably bilaterally because the AHL is weak. So she has got L5, S1, predominantly L5, S1, S2 because of the cloth deformity and the absent ankle. It is less likely to be due to the diabetic neuropathy per se because her sural potential was normal. That's less likely.
Some help in cutting of trees, no? So that can produce the strength of this protrusion.
Yes.
Pressing the L5, S1, S2 roots.
Correct. You're right. That's the clue. That is the clue in this. Some noise is coming from the back. I don't know which. Somebody please see that noise is not coming, please. So this is the, so in MRI, this is MRI of the spine, LS spine. See, it's got a central disc prolapse at L5 S1. Again, you can see the central disc prolapse compressing the. You can find out that thing. Bilateral, already pre-existing upper facial joint thickening and canal stenosis. And this is showing the central disc prolapse in the center. So L5 is also there, but more predominantly L1 and S2 on the left side in addition. So that's the story. Only about the case to how the people can present. They did not complain of any root pain at all. No back pain initially, only problem in getting it. And it was complaining, since the roots affected predominantly S2 and less of S1, that is why they're complaining of hip and gluteal pain and heaviness there and things like that.
So did she have back pain, low back pain?
She did not complain. That's a kind of thing. He never complained low back pain.
Yeah.
She was pointing to some heaviness of the trunk, back, lower back, as well as in the gluteal region.
Yeah. Many of them do that.
Yeah.
But improving within 2 days of
3 days.
without any treatment is.
Yeah, correct. She took bed rest. You know that. She took
Thank God some neurosurgeon did not see her.
Sir, one doubt.
Yeah. Yeah.
The left foot, she has claw deformity, no, sir?
Correct.
So within this 1 month, can it develop?
Yes. Can develop. It can develop. In nerve lesion, they can develop quite rapidly. If you got a root lesion, a single root lesion seldom produce any significant weakness. There will be multiple roots. It has to be multiple root has to be affected.
So this patient had a disc disease, disc protrusion causing radiculopathy, and also had a neuropathy, common perennial neuropathy separately.
Yeah, that's separate common
which was incidental.
Incident.
Now the other thing is that would you consider by any chance of imagination diabetic amyotrophy in this patient, or what you call lumbosacral?
In fact, that's one possibility kept in the history. But after examination, she had no weakness of the proximal muscles, no tight tenderness. Knee jacks were normal. So we are not fitting with the amyotrophy at all. And the history of some heaviness in the back. And that's the thing. And again, improvement over few days times with lot. The person severe enough to put is unable to get up from the bed.
Yeah.
The clue was that again, what you have to think logically as this is telling about not for the consultant, for the students. When the peripheral condition is normal, and the patient's got some neurological deficit like numbness and weakness, you have to think if there's lesion could be proximal in the root. The diabetic naturally we think of a peripheral neuropathy, but peripheral condition is normal means the problem is proximal. So you have to do electrophysiological tests like SSCP or due to the long latency reflexes like H reflex and FA. The help of those reflexes to localize. That is why you go for H. Usually we don't do H reflexes. Here in this situation, especially tibial or S1 root is affected, you have to go for H reflex. Okay.
Sir, clinically, how far you can it be?
Would this patient's small muscle weakness improve with discectomy?
I did not get you, please. Can you speak once again?
Would this patient's small muscle weakness of the feet improve with discectomy?
No, nothing was done in this patient. Only bed rest was given. She improved without any surgery, everything. Nothing was there. Only injection was given. No surgery was done in this patient. Because I sent her with a lumbar corset, said that you improved remarkably, only mild deficit. Later forget that mild wasting. That's what I said. It's not going to cause any problem to her. She needs only conservative treatment.
So initially she had difficulty in walking. That could be due to the hip abduction extensor weakness.
Yeah, hip abduction weakness. Because from the degree of weakness she had initially, she was improved remarkably. So I thought we'll wait with the lumbar corset and see how he's improving or not.
But the patient was not examined during initial days. Could it be a stroke, or mild stroke which has improved? This could be unrelated radiculopathy alpha old.
In fact, I couldn't hear you. Can you speak a little more slowly?
So this episode, she was not examined in the initial 1 week when she had difficulty in walking. Could it be a minor stroke? This while now the examination could be the old alpha radiculopathy.
Yeah, correct. So we are not examined at that time, no? She came to me now. This is the finding now. At that time,
so that could be a minor stroke also. The first day she improved in 1 to 2 days. Could it be a minor stroke that could have happened?
No, that's very unlikely. How can a minor stroke occur both lower limbs simultaneously? And unless you think of an ACA, unpaired ACA occlusion, that's a very rare possibility, remote possibility. I think we should not consider that possibility. Otherwise, if a unilateral one limb, again, I would perfectly agree with you. It can be due to an unrelated stroke. And she was consistently pointing, while the complaint has come, she has got some heaviness on the back, some funny sensation inside the bowel, during defecation. Those things are the complaint. I have to address that complaint also. Otherwise, if it is one limb, I would have perfectly agreed with a unrelated stroke as a possibility of a sudden onset of weakness. Agreed.
But then with the pain, we can think of the local.
Yes.
So,
So, shall I show one more case?
one doubt,
Yes,
sir.
sir.
Yeah, please.
How common is the clawfoot due to L5S1 radiculopathy? S1 is 2 radiculopathy. How common is it, sir? Because we don't usually see.
You mean radiculopathy?
Yes, sir. The clawfoot you told you to the S1 radiculopathy, no, so S1, S2. How common is it, sir?
No, it is not very common. It all depends upon which muscles are affected, which roots are affected. In ordinary disc prolapse, that roots are not commonly affected unless it's a central disc prolapse. The central disc prolapse can affect bilaterally, then one cell may be more affected than the other. That root can be S2 root, S3, S4, everything can get involved. They can come with retention urine and all. Here also the affection is bilateral, but asymmetrically more on one side. That is where her bladder is not very much affected, but still she has got that sensation of some, she's pointing to the whole buttocks regions and membranous is there during defecation. That means her bilateral roots are in fact affected symptomatically, but deficit was not very severe. Or you can think the clawfoot deformity is unrelated person earlier. That's quite right. That nobody can deny. But why I'm telling that her sensory loss, her weakness, reflex loss, everything is in the distribution there. Otherwise, you can definitely think that clawfoot deformity unilateral is unrelated. If it is bilateral present from early, it could have been more like an unrelated one. Unilateral one, you have to always think of a structural pathology. I mean, always what's a new lesion has come. That's your thing, not present from birth onwards. Okay. Shall I go to the next case, Subhad, or shall we stop?
Yeah, please go. Please go ahead, sir.
Okay. I'll show you one more interesting case. A 24-year-old man who has been on treatment with heptoin the last 5 years for seizure disorder. He has presented with history of unsteadiness in gait for the last 1 year and numbness of both feet for the last 2 years. Okay? This is a story. The unsteadiness is more at night. Last attack of seizure was 1 month back. No other 11 history. Okay? It's not a diabetic. So history of patient on heptoin, unsteadiness for 1 year, numbness of both feet which is aggravated at night. On examination, the moments are normal. There was no nystagmus. Upper lip power normal. In fact, all power were normal. Tone was normal. No incoordination. The muscle power is normal. Tone was normal. Itia, the upper limb, biceps, and supinator was decreased. Biceps was irritable. Supinator is less bilaterally. Biceps normally irritable. Biceps also normal. But supinator was absent. Finger pressure was also absent. Abdominal press was irritable. Knee jack and ankle jack both were absent.
ഞാൻ ചെല്ലുമ്പോൾ കഞ്ഞി പിടിച്ചു പിടിക്കണേ, വലിച്ചു പിടിക്കേ, വെള്ളം കൊടുക്കാതിരിക്കേ. കൈ വെച്ചിങ്ങ, കഞ്ഞി വലിച്ചു പിടിങ്ങ.
Plantar was indefinite.
ഒന്നും ചെയ്യാനില്ല. കുത്തി മുകളിൽ വരുമ്പോൾ എല്ലാം ഒരേ
Meditation will decrease the distal part of the feet.
இது கூடுதலா கம்மியா? இங்க கம்மியா இருக்கு. ஜாஸ்தியா நம்ம சொல்லணும்.
There he is able to feel normally.
கம்மியா?
But the mid.
ஜாஸ்தியா நம்ம சொல்லுங்க.
Vibration is normal in the upper limb.
தெரியுதுல்ல? இப்போ இல்ல.
It's absent over the toes.
கம்மியா இருக்கு, தெரியுது.
Decrease.
இப்போ தெரியுது.
Present over the ankle.
இந்த சில மோல்ல ஆக்கு. எங்க ஆக்குன்னு சொல்லணும் என்ன? இப்போ எப்படி? இப்போ கீழே, இப்போ மேலே, இப்போ கீழே.
His joint sensors decrease to the right mid. It is present, but he's making some mistakes.
சரி. எப்படி?
That is lost in the over the
தெரியல.
It's not able to feel at all.
தெரியல. இப்போ தெரியல.
Not able to.
இப்போ தெரியல.
Even the angle was decreased.
மடக்கு தெரியாதுன்னு சொல்லுங்க. இப்போ தெரியுதா இல்லையா?
He's able to feel only with large amplitude movement.
இப்போ நான் இப்போ மடக்கேன்ல, அஞ்சுக்கு தெரியுதா இல்லையா? இப்போ தெரியுது. இப்போ
Thrombus is positive, but not very severely possible. Stay definitely swaying when it eyes closed. Gait was normal. Tandem walking was slightly different.
சும்மா கிடையாது. திருப்பி நடைங்க, திருப்பி நடைங்க, திருப்பி 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 ஸ்பீடு நடைங்க.
Only history considers more during night. Okay, that's the findings. Tailor's normal, tone power normal in both upper and lower limbs. The upper limb, biceps and triceps normal, absent supinate and finger percent reflexes. Lower limb, both knee and ankle joints are absent. Supraspinatus, subdominal plus normal, plantar indefinite. Sensory system, primary modalities impaired pain in the distal part of both legs, impaired vibration over both toes, normal over the lateral malleoli, normal vibration in the upper limb. JPS impaired over the fingers as well as over the toes, but definitely only on the finger, toes and ankle. Thrombus positive, gait normal, tandem walking defect. So, where is the site of lesion in this case?
Peripheral nerve.
Yeah, most likely peripheral neuropathy, right? So, what could be the reason for the peripheral neuropathy? We don't know, right?
Joint.
Yeah, sensory peripheral neuropathy, predominantly joints. Yes.
Yes, joint.
Joint induced peripheral neuropathy have you ever seen? But they describe the literature, but he given the complaint of function, there's no nystagmus, no cerebellar incontinence in the upper limb. If joint induced peripheral neuropathy, you can postulate, but I think it's distinctly rare. I've never seen one.
Agloblastic anemia. Secondary tertiary.
Secondary, right? What anemia?
Agloblastic anemia producing
Right.
fetal deficiency.
Fetal deficiency, yeah. Right, that's a possibility just receiving. Okay. Let us see. First, we have to localize, no, whether it is in the posterior column, whether it is in the peripheral nerves, whether it's the root. Let us see. So, peripheral neuropathy, what investigation you need? ESR was normal, 3 millimeters. FPS, BP is normal, TSH normal. Vitamin B12, 526 normal.
Homosexual.
No megaloblastic picture in the bed picture. There is normocytic, normochromic anemia. No normocytic, normochromic picture, no anemia. Motor conduction normal. I'm not saying the conduction is normal. Motor power is also normal. Later. What we are interested in the sensory potential. This is sensory potential. All normal. What do you want now?
Could be lat posterior column.
Yeah. But has he got peripheral neuropathy or not?
No, sir, because the sensory conductions are all normal. Plus the motor
But he has
conduction.
got absent knee and ankle jack.
That
Absent this thing, supinated jack also. Forget about the supinated, at least you can say absent knee and ankle jack. Where the sensory loss is there, is impaired joint sense, positive rhombogism, and absent ankle jack. He has. Only thing is that the dish has to be proximal to the ganglion. Yeah. So as we think of a sensory radiculopathy, then they take a CASP or to consider in such situation. When you put a sensory reflex loss and proprioceptive loss, and the conduction is normal, there is to be preganglionic. Okay, that's the thing you have to keep in mind. The preganglionic lesion can also put his posterior column, because ultimately what is posterior column? Nothing but the central process of the sensory ganglion. The peripheral process comes below, central process goes upward. So in sensory polyradiculopathies, you can have posterior column lesion also, posterior dysfunction also. But the reflexes will be preserved in posterior column. Okay. Right? So what do you want now?
MRI of the spine.
Which spine you want?
Lumbocyclus cervical.
Okay, fold spine. We'll take fold spine. Okay. So lumbocycle spine was taken normal. So we did a contrast study because of the tool or CASP. That is no contrast. That picture I have not shown. What else you want? Cervical you want. Cervical. The cervical MRI. So one more this axial cut of cervical MRI. Reported to be normal. What else you need? Brain you want? When your brain was taken, that is also normal. This is the brain MRI. The medulla, etc. MRI dorsal spine. MRI dorsal spine showed some compression of the cord anteriorly like this. I'll show the axial cut. The osteophytic protrusion on the vertebra, projecting and compressing the thoracic cord on the left side. Ventrolateral compression of the thoracic cord by a calcified osteophyte.
but that cannot explain any of the findings.
Correct. Obviously, that cannot explain. That's the thing I wanted you to think. So when you find something in the MRI, don't think it's related, it's totally unrelated. Forget about that osteophyte. But we have to make a diagnosis. What do you want now?
CSF tubular radiculopathy.
CSF you want?
Yes.
Okay. No, I told before, I got a good radiologist to pursue the, he makes most of the diagnosis for us. Because he said, I went back again, I said, you have to look carefully for the posterior column. There is a lesion in the posterior column to produce sensitive but normal, not fitting with the enhancement. He has got peripheral neuropathy, but with the normal condition, you have to roll a posterior column. So you screen for the posterior column very carefully. So he did, in fact, we looked at the MRI once again. Do you find any abnormality there in the MRI? Look at the cuneate nucleus. Do you have some hyperintensity there? we found hyperintensity. In fact, I pointed out something subnormal there. I wanted to pursue that thing. So he then took another cut again. He did diffusion sequences of the lower part of the medulla. And see, look at what is happening in the cuneate nucleus. Now you can make out the cuneate nucleus, the lowermost part of the medulla, the gracile cuneate nucleus is hyperintense. Did you make out now? Uppermost part of the posterior column and the cuneate and gracile nucleus. Now this is the still sequence, the still sequence, or the flare sequence, 3D flare sequence would take a little more and thin sections they take in 3D flare. We can make out the hyperintensity very well in the nucleus cuneatus. In this 3D flare showing hyperintensity. It's something like a heart shape. You see that? The nucleus is bulging out, and below that the posterior. But it's not coming down onto the cervical cord. Only the cervical but the rejection is there. Again, you can make out some rounded hyperintensity there. So MD3 flare and diffuse study the cervical multi-junction shows hyperintensity in the hyperintensity and diffuse restriction in the fasciculus and nucleus gracilis and cuneatus. So now we know what is causing his imbalance, mainly due to the posterior column, but he has got a subclinical neuropathy as well, causing reflux loss. But the reflux loss of the neuropathy is not responsible for its unchilliness. Unchilliness is in fact due to the posterior column. If neuropathy had been the reason for its unchilliness, in fact, the condition should have been abnormal. So that's not the problem. That's unlikely to be very significantly affected. If the reflex carrying fibers are affected alone, why should unchilliness occur? It should be the fibers which carry the posterior column should be affected. In that case, if it is repetitive, the condition should have been affected because it is a proprioceptive input fibers and large fibers. So you have the posterior column is the culprit. Now we have to find out what caused the posterior column. So what else you need in this? Very good. So the next question is the CD affecting the nucleus gracilis? See the homocysteine.
Folate deficiency.
Pardon?
Folate deficiency.
Folate also you have to do, but homocysteine is grossly elevated. So it may be a deficiency of the vitamin B12 and folate. You have to supplement both because of that, which he has been on a time. So what is the diagnosis now? Is and we did a parietal cell antibody to find out due to the pernicious anemia that was negative. So patient improved remarkably with vitamin B12, and next day he came senseless, everything subsided. So that's the story. Any questions in this case? What?
Yeah, no. It's a great case. Yeah.
Suppose the MRI is like normal also, the explanation of ataxia cannot be with the peripheral nerve.
Yeah,
but even then, because the patient is on Neptune, we can always give the vitamin B12.
That of course in the management part you can do that. The problem is that as a neurologist, we have to find out what is causing it. See, ataxia means, sensory ataxia means the proprioceptive fibers are affected. The fibers are going in the peripheral nerve through the root and the dorsal column and reaching. So we know somewhere in that pathway is affected. If it has been distal to the ganglion, invariably conduction will be abnormal because conduction picks up only large fiber lesions. This ataxia is also large fiber lesion. If it is a small fiber, naturally conduction can be normal even in neuropathy. So that part is, distal part is excluded. Other thing is proximal to the ganglion. CASP proximality can be ruled out now, even now. But nothing that was there in the root enhancement, nothing was there. But we should have done a CSF also. But before that, I want to hold a posterior column. But the commonest condition for is posterior column and neuropathy is subacute combined degeneration. So we pursued with the posterior column. So posterior column is keen all throughout. Initially, we did not pick up the this thing, abnormality in the MRI of the cervical spine, because it was overlooked. That's why they went and do the MRI of the brain, which is normal. Then on pursuing further, on insistence, they did the small further refinement of the cuts to find out what was happening in that region. Normally, it gets overlooked, that particular small hyperdensity in the T2.
So the first MRI sagittal view itself was showing that subtle.
Yeah, it is showing, subtly it's showing, correct, you're right. That, because that only when the clinical suspicion is there, we go and look back again.
Okay.
Okay, that's the point. See, we are all busy dealing, seeing so many cases. We someday rely only on the report of the patient. So what is it? MRI, just casual look, MRI are normal, okay, normal. But if you think back and explain why it is causing like that, then only you can look carefully and for the abnormality.
So the point, Madhu, which I would like to make, is that very often we are these days seeing that you can have a B12 deficiency in the presence of normal B12 levels.
Correct, perfect.
Like this 500, 600, normally we would brush it as normal, but yet they may be having a deficiency at a cellular level, and homocysteine we should always combine with homocysteine, I think.
Absolutely.
And I think, one must look for, I have seen some patients where there was this similar appearance of posterior columns involvement in MRI, but B12 was normal, and they responded to B12 eventually.
Correct.
But other thing is, for the sake of students, that what is the differential diagnosis of this kind of I think copper deficiency can also cause probably same MRI picture, Madhu? What do you think?
This can occur with copper deficiency, HIV myelopathy, tractopathy due to paraneoplastic syndrome, nitrous oxide intoxication. These are all folate deficiency, and methylene tetrahydrofolate deficiency is a genetic condition. All this can cause this kind of an hyperdensity in the posterior part.
Yeah. Thank you, sir. Thank you so much.
Zinc deficiencies, zinc intoxications are the condition. Zinc intoxication in effect causes copper deficiency.
What intoxication? Zinc
sulfate.
Okay, sir.
So how to explain the absent ankle and
no, they have peripheral neuropathy. Perfectly right. They have peripheral neuropathy, but peripheral neuropathy is subclinical. No, that's the point. See, when you get absent angle jack and decreased posture, naturally is peripheral neuropathy, but the conduction is normal. That is why you have to pursue further. If conduction was abnormal, nobody would take an MRI in this patient.
Yeah.
But MCS is normal and ankle jack is absent. How common it is?
Ankle jack is absent because of peripheral neuropathy.
For ankle jack to be absent, MCS is normal. So no conduction.
What is normal? What is normal?
Nerve conduction.
Nerve conduction is normal.
And that's what I said. There is peripheral neuropathy in this patient. The peripheral nerve contains fibers which carry reflex fibers, large fibers carrying the proprioceptive sensor like joint cells on the periphery, as well as the pain and temperature fibers. If the neuropathy affects predominantly the reflex carrying fibers, only reflex will be lost. Just like for what you see in Miller-Fisher syndrome. In Miller-Fisher syndrome, only the proprioceptive input in the muscle spindles are affected. That fibers are affected by neuropathy, you won't get any sensory loss. You won't get joint pressure sense, only reflex loss will be there. If large fibers are affected, carrying the proprioceptive input from the skin and bones and joints and all, they will have impaired sensation as well as nerve conduction abnormality, because nerve conduction abnormality picks up input from those fibers. If pain and temperature fibers are affected, pain and temperature will be lost, but conduction will be normal, because conduction will not pick up abnormality at small fibers. So this only shows that the vulnerability or selective affection of certain fibers to the peripheral nerves causing the reflex loss.
So reflex carrying fibers can be affected, and even in that situation, sometimes NCS may be normal. That's what you're saying.
Exactly.
Because we normally think reflex conducting fibers are large fibers, so we would expect NCS to be affected, but that need not be so.
Need not be. Classical example is Miller-Fisher syndrome, where you get reflexia is global reflexia, but you find Johnson is normal most of the time.
Okay, Madhu, thank you.
And
Usually you see in the spinal cord, no, sir, that the signal intensities, but none of the cuts were showing that.
even axial cut.
Spinal cord, the entire spinal cord, posterior column, we could not find any signal intensity.
Exactly. The lesion was only in the nucleus and just below that. That's a very unusual case. No described literature.
Sir, will you do a MRI to just see whether the restriction deficient has disappeared or not? Like,
yeah, because the patient not come after he's become very. This happens, no? When the patient becomes already, they don't come back for follow. He never came.
Yeah.
No, how you must have observed that I've seen patients, for example, in multiple sclerosis patient, due to posterior column involvement, they have got normal joint presence, sense, everything, but they have got sensory attacks. The moment they close the eye, they fall down.
Yeah.
This I have seen. The other way around also is there. The patient's got profound proprioceptive, not much of a rhombus positivity. So that means this all the fibers are not. The fibers, the posterior column are for conscious perceptions different, and those meant for your the coordination part is different. Quoting in other words, fibers going for a parietal lobe and those going to the cerebellum are different. They may be differently affected. That is why
I have seen this disconnect many times.
That's
why I clarified.
Yeah.
You know, and then sometimes you see what happens is that it is not. Although we say neurology is mathematics, but I don't think neurology is mathematics. It is something beyond mathematics, you see, because it also depends upon the threshold at which nerve conduction comes, abnormalities. And at a threshold at which we pick up, even if large fibers are involved, at a threshold at which we pick up nerve conduction abnormalities, the clinical symptoms may come below that threshold, before that threshold is reached. Patient's perception of unsteadiness may come at a level of large fiber at which nerve conductions may be normal. So, yeah, you know, so that can happen. But then we learn from you all these things.
No, these are only practically which have say we burned our fingers and learned by mistakes. No, so that is experience. You know, these are only by observation. I find the many members patients I find severe ataxia and for joint sense is perfectly normal, but they cannot stand with the feet closed.
Yeah.
Without positive rhombus.
Yes, sir. I think, Madhu, we are very fortunate that you hold this class every week. I think it is most valuable. It is not available anywhere in the world, you know.
I am also learning so many things from you already.
Now we can read. After this discussion, we can read these topics, and you know that will. Thank you, sir. Thank you so much.
Okay. So shall we call it a day then? Okay.
If there are no questions or comments,
any questions?
No, sir.
Okay. So
thank you, sir.
Thank you, Paul. Thank you all for your patient listening. Thank you.
Thank
we'll
you.
meet next Sunday. Yeah, Sunday.